We're doing Module 3, Elimination. By the end of this module, you should be able to describe the physiological process involved in the maintenance and restoration of health and wellness, describe nursing interventions that promote normal bowel and urinary elimination, and identify nursing diagnosis associated with altered urinary elimination. These are a good FYI nursing strategy. Mnemonic for the nursing assessing pain. You can do it as PQRST. Provoke, what provokes the pain. Quality, what makes it worse, what makes it better, what does it feel like. Radiation, where is it, where does it radiate. Severity, what's the pain on a 1 to 10 scale. Time and treatment, how long have you had it, what has already been done. These are good ones. It's the same idea as your 2Ds, describe duration, and your 2As, alleviate and aggravate. We're going to do the bowel elimination. This goes in just saying what the anatomy and physiology of the GI tract is, from the mouth all the way down to the anus. You do not need to know this for the test, but it is good to know it. How does the developmental state impact bowel elimination? The biggest thing to remember is severe diarrhea can cause fluid and electrolyte imbalance. And that's the biggest thing that you should know. Medications that can affect elimination are antacids, aspirin and NSAIDs, antibiotics, iron, pain medications, anti-mobility drugs, and laxatives. We know antacids are for the heartburns. Aspirins and NSAIDs we know can affect the stomach. Antibiotics can end up having a secondary gain to it. Iron usually can make people constipated and black stools. Pain medications we know can make it so that patients get constipated. And then you have your anti-mobility like Modium, and then your laxatives. You want to look for different things in your assessments: family history, past abdominal history, eating habits, nutritional assessment, dysphagia, nausea, vomiting, and pain. You also want to look at their history of nausea, vomiting, pain, location, intensity, onset frequency. You want to look at the frequency, consistency, the color of the stool, the odor, or color of the bowels, the odor of the bowels. You want to look at dyspepsia, dysphagia, frequency of symptoms, how much do these symptoms affect your life. You also know that there can be heartburn, painful swallowing, which is odonophagia. Difficult swallowing we know is dysphagia. Indigestion is your dyspepsia. Along with the nausea, vomiting, you want to be seeing if they're queasy or feel like regurgitating. Could be just as simple as the hiccups they're having. It could be GI gas. We're going to keep assessing. We're going to do abdominal pain, whether it's acute, chronic, referred pain, rebound pain, and then we have the abdominal assessment. So it's the inspection, auscultation, percussion, and then palpitation. For the assessment of the abdomen, we know I just named the 4. So when you auscultate, you do the abdominal quadrants for bowel sounds. You should be hearing high-pitched, and you should use the diaphragm of your stethoscope. According to the book, when you percuss, you want to begin in the right lower quadrant, then go the right upper. So instead of actually going clockwise, they go counterclockwise. You want to note when timpani changes to dullness, because that means it's over the organs. That's a good way to kind of understand where you are in regards to like the liver. Otherwise, you're going to hear air, because that's air in the stomach and the intestines. And then you never want to palpate over areas where brutes are auscultated. And then when we talk about the assessment of bowels, normal bowel sounds are high-pitched with 5 to 15 gurgles per minute. Your hyperactive bowels are very high-pitched, and then they're more frequent than normal. These can occur with small bowel obstructions and inflammatory disorders, and they can produce diarrhea. Your hypoactive are low-pitched, infrequent, and quiet. A decrease in sound indicates peristalsis, and then it can cause constipation. Absent bowels, if you hear nothing after 3 to 5 minutes, they're considered absent. It can indicate a paralytic ileus, and sometimes they'll say that when you don't hear anything, they call it a dead bowel. Then we'll go on. Here's some tests that you can do: the abdominal flat, barium enema, ultrasonography, CT, oral or IV contrast, MRI, EGD, sigmoidoscopy, colonoscopy, and fecal occult blood testing. When you want to promote normal defecation, you want to provide privacy, assist with positioning, the timing of the defecation, healthy food intake, fibers containing foods, adequate fluid intake, and then encourage exercise. Treatments for constipation, we do laxatives, enemas, and sometimes you even have to do digital stimulus, or it's digital removal. For diarrhea, kind of watch diet and fluids, so you'll do the BRAT, which we know is bananas, rice, applesauce, toast, fiber, and water. For prevention with constipation, you want to have a daily intake of 25 to 30 milligrams of fiber, because you want to promote peristalsis. You should drink at least 1,500 to 2,000 mils of fluid a day, and the fluid can be water, juices, anything to increase peristalsis. With diarrhea, remember that severe diarrhea can cause perineal excoriation. So for perineal care, you want to change clothing and bedding as soon as possible. After the incontinence, you want to wash with soap and warm water, rinse and pat dry, and then you want to use barrier creams for irritated skin. And then it goes on to name many nursing diagnoses that you have probably seen before. Talk about planning, outcomes, and evaluation. So you have general goal: patient will have soft form bowel movements regular, resume normal bowel pattern, and then if they have a colostomy or anything like that, you want them to be able to discuss their feelings regarding that. And here is the list of terms that you should know. And they're good ones to know, because throughout your career you'll run into them. Characteristics of urine: you have specific gravity. It's a measure of the amount of dissolved solutes in a solution. So normal is 1.01 to 1.030. If you have too much, you're going to have dehydration, and if your numbers are low, you're going to have overhydration. You want to check the quantity. So how much have they been going, the color, concentration, the odor. You also want to look and see what the developmental stages for urinary for infants, childs, and older adults. Some of the age-related changes in the renal system are, and as a nurse we should be aware of these, decreased muscle tone and elasticity in the ureters, bladder, urinary sphincter, and surrounding structures. This could result in problems of incontinence. In prostatic hyperplasia in the male, this results in urinary retention, decreased functioning nephrons, and decreased glomerular filtration rate. This can be reflected in slightly higher blood levels of urea nitrogen and creatinine. And then you can have nocturia, which may result from problems of retention or decreases in renal concentration. Things that affect urine output: diuretics like coffee, tea, soda, chocolate, alcohol. High sodium intake can do it. Bladder irritants like coffee, smoking, alcohol, cold weather. Physical activity like perspiration, fluid loss. That's where you run into seeing dehydration, especially in runners. Then we have medications. Pyridium is one that you see used for UTIs that helps the painful urination. And then you just want to let the patient know that will turn their urine orange, and that's normal. They shouldn't freak. Diuretic medications, you have your thiazide, potassium sparing versus your potassium wasting. The loop acting diuretics, which is like your Lasix. When you're teaching, you want to tell the patient, take the medication at the same time each day. Best time is morning and early evening. Do not take it before bedtime or you're going to be up all night going to the bathroom. You don't want to drink tea or coffee because they're diuretics and they can actually cause severe dehydration as they are doing the same thing that your medication's doing. And if they do have tinnitus, that's an indication of ototoxicity. So that's not a normal side effect they should be getting. If they are having it, that means that they have too much. And a common side effect is orthostatic hypotension. If they do have edema, they need to report that to the doctor. With your urinalysis, they're going to look at color, pH, specific gravity, clarity, odor, the protein, glucose, ketones, whether there's blood in it, and the bilirubin. We also have to remember that some vegetables themselves will give odor, smell like asparagus. Some blood studies that they do is the BUN. If there's an increase in a BUN, you may see that there's dehydration going on. And they also will do a creatinine, which you'll notice when they do a 24-hour, it's usually a creatinine clearance. Diagnostic studies that you would see, a CUB, which is kidney urinary bladder x-ray, and this will show the presence of renal calculi. You could do CT, MRI, nuclear scans, IVP, or renal angiography. The IVP, you need to assess the patient for any allergies to iodine. The clinical manifestations of this allergic reaction is the same as anaphylaxis, so you want to immediately give them epinephrine. And for preventive purposes, we need to ask them if they're allergic to iodine, eggs, or shellfish. And if they are, then we want to make sure that they don't take the test. Risks for UTIs are sexually active women, having new sexual partners. The reasoning is the bacteria in the urethra. So you're getting introduced to new bacteria all the time with multiple partners. Women who use spermicidal contraceptive gel, postmenopausal women, pregnant women, men with enlarged prostate, uncircumcised men, kidney stones, indwelling catheter, diabetes mellitus, immune compromised patients, and anyone with a history of UTIs. Signs and symptoms that you would see would be back pain or low abdominal pain, bladder spasms, chills, dysuria, edema, fever, foul smelling urine, hematuria, nausea, vomiting, urgency and frequency. The best way to prevent a UTI is to drink at least 8 to 10 8-ounce glasses of fluid to keep the urine dilute and flush out the bacteria. You want to urinate when you first feel the urge. The longer the urine stays in your bladder, it becomes stagnant and bacteria will multiply. You want to wipe from front to back. Wear cotton underwear, not nylon or synthetic fabrics, because they will not prevent evaporation of moisture, or they prevent evaporation of moisture. You want to urinate after intercourse because there's bacteria in the urethra, which if you don't flush it out, then that gets into the urine. If you have a history of UTI, avoid using diaphragm, spermicidal contraceptive gel, or unlubricated or spermicidal condoms, and you want to make sure you avoid bubble baths and baking soda baths. We play a huge role in preventing UTIs, so we want to make sure that we practice strict aseptic technique and catheter insertions, and throughout, we also want to do regular perineal and catheter site cleansing when there is a urinary catheter present. We have the different types of urinary incontinence. We have urge incontinence, whereas it's kind of an overactivity. There's a precipitous loss of urine. It's preceded by a strong urge to void. It can occur in healthy persons, but often is found in chronic disorders like diabetes, stroke, or Alzheimer's, and it can sometimes be an early sign of bladder cancer. Stress, that's where you're going to see that the sphincter is, the anatomy, it's normal, but it's lost some of its efficiency, so it's kind of lost some muscle tone. That's where you see urine leaks during exercise, coughing, sneezing, laughing, lifting heavy objects, or any body movements that put pressure on the bladder. It's the most common type of bladder control problem in younger and middle-aged women. So you want to make sure of that. You have the mixed and overflow incontinence, and then you have the functional incontinence, which this happens in older people who have normal bladder control, but because they maybe have arthritis or any other disorder that makes it difficult for them to move quickly, they'll be incontinent of urine. So it won't be that it's really anything wrong with the bladder, it's just that they can't move fast enough to get to the bathroom. Then you have the transient unconscious enuresis and nocturnal enuresis. We have the different types of urinary dysfunction. We have interstitial cystitis, pyelonephritis. Remember that signs and symptoms of pyelonephritis are rapid onset of fever and chills. It has flank pain, pyorrhea, nausea, vomiting, and headaches. The urine test will reveal that there is bacteria, and they'll also have white blood cells and casts in their urine. Glomerulonephritis, remember that one way indicator of this is if in the history they ask if they've had a recent strep throat. That is a huge indicator of somebody that has glomerulonephritis. Then you have nephrotic syndrome, renal tuberculosis, urinary tract calculi or the stones, and then the last three. Self-care for kidney stones. You want to make sure they're drinking lots of fluids. Water, lemonade, most fruit juices can help dilute the substances in the urine that form kidney stones, but you want to avoid grapefruit juice and soft drinks. You do not want to eat too much animal protein, so diets high in protein are linked to an increase in calcium in the urine, which increases to making more oxalate stones. So you want to stay away from smoked fish. Avoid organic acids, oxalates that help stones form. You want to limit intake of spinach, rhubarb, beet greens, nuts, chocolate, tea, bran almonds, because these also increase urinary oxalate levels. You want to supplement with vitamin B6 and magnesium, and you preferably should take magnesium citrate. These actually inhibit oxalate stone formation, and then monitor your calcium intake. And then you also find nursing diagnoses that go with urinary elimination. For our assessment, we want to get a health history. We want to assess their urine patterns, so frequency, urgency, color, and odor, and then see what type of medications they're on. And this planning outcome is more to help with urination. So you want to provide privacy, assist with positioning, facilitate their toileting routines, promote fluids and nutrition, and then assist with hygiene.